Hello and namaskar to everyone here. Wishes and prayers for everyone's health and happiness. This is a GSI session in AIOS APAO 2025. I am Dr. Satyan and President of GSI. We are waiting for Dr. Manish. He is our Secretary GSI. We have Dr. Devet Tuli, our Treasurer. We are waiting for Dr. Rajul to join in from Senior Consultant from Mumbai. We have Dr. Sunita Dubey, Senior Consultant from Shraf, Delhi. And we have a mix of speakers, the young gen to the reasonably elderly gen. And same way we have the Kadambam. The topic is a mix of all. So it is basically a very practical session and there's a lot of take-home messages for the audience. We are just hoping that we have more audience sooner. So over to you, Devan, to invite the speakers.
You can start with the first.
Okay. So we have Dr. Faisal. We'll introduce the speakers as and when the topic starts. We have Dr. Faisal from PGH Chandigarh. He's going to enlighten us with the cornea. Yeah. How cornea is relevant to us in today's glaucoma practice. Over to you, Dr. Faisal.
Very good morning, everybody, and thanks Dr. Satyan and GSI for giving an opportunity to talk this topic, that is the corneal hysteresis and biomechanics in concomitant glaucoma diagnosis. As we know, few decades, maybe a decade back, when the aura came into the market, there was a lot of enthusiasm for this corneal biomechanics and corneal hysteresis. There were a lot of mushrooms of publications in corneal biomechanics. Then after 2013, this publication number has come down and there is a kind of stagnant kind of thing. Then whenever new machines came like Corvus ST, there are few publications came about corneal hysteresis. So I'll be just talking about a little bit introduction of the corneal biomechanics and the how we can fit this into the day-to-day practice. So as you know, biomechanics for any substance or in corneas means the assessment of the deformation and the equilibrium of corneal tissue under any kind of application of the force. We know our cornea has good two properties, that is the elasticity and the viscous behavior. Both are essential for for the corneal day-to-day functions. So the elasticity, that is the main load of bearing this stress, that is by the collagen fibers, and the extracellular matrix, that is the ground substance, offer its viscosity. So what is corneal biomechanics? As we know, CCT says static parameters, but corneal biomechanics like corneal hysteresis, corneal resistance factors, these are not mechanical static factors, these are dynamic in nature. The measurement is also affected by the type of the stress and the rate at which the stress applied, location of the cornea where the stress applied, and the IOP, as well as the age and the axial length also. So for glaucomatologists, what is importance, relevance of glaucoma, this corneal hysteresis in our day-to-day practice? So corneal biomechanics may play a role, important role in the maybe an accurate measurement of the IOP, which is the only modifiable factor as of now, or this can be used as a global surrogate marker of the eye. That means we cannot measure the compliance or corneal biomechanics of the lamina cribrosa. So corneal biomechanics can have a surrogate marker of the overall globe biomechanics. So as I already told, there is two instruments mainly used. The initial one, the ocular response analyzer, started in 2006. Then lot of studies, or more than 500 studies, you can index studies, you can get ORR related in corneal biomechanics. And the later on Corvus came, and a few studies also came in the Corvus also. So what is hysteresis means? This is the viscous damping ability of the cornea. Or in simple word, hysteresis means lagging behind. That is the difference between how a material deform and reform during loading and unloading from an applied force, as shown in this picture. Then what is the normal value? Normal value is 9.6 to 10.7 millimeter of mercury. So in simple term, eye with low corneal hysteresis would have a poor shock absorption properties. That means this eye, that means eye with low corneal hysteresis will have more prone for IOP-induced stress and strain and the subsequent glaucoma damage. So what is the impact of corneal CCT on corneal hysteresis? CCT in a normal healthy subject, there is a strong positive correlation with CCT and corneal hysteresis. But in practice in glaucoma patients, though there is a positive correlation, but the correlation between the corneal hysteresis and CCT is weak positive correlation. So I searched this, how we can fit this into our day to practice. We have at least more than 500 indexed publications which studied about the corneal biomechanics. So how IOP affect the corneal hysteresis? IOP is negatively correlated with corneal hysteresis such that high IOP, there is a lower corneal hysteresis. As the IOP increases, the cornea becomes stiffer and its damping ability reduces. But in other scenario, as in chicken and egg scenario, low IOP means, low corneal hysteresis means more stiffness. That means more stiffness means you need more force to applanate or indent. So that means you are recording, you may getting a high IOP recording. So that's why the relation between the IOP and the CCT is not like a straightforward. That means IOP increases, corneal hysteresis decreases. That is not the real scenario. So what the literature said that in POIG, all studies agreed that there is lower corneal hysteresis as compared to the healthy control. We also conducted a study in 2012. That study also agreed this same finding. POIG has less corneal hysteresis. While in NTG, the pressure is normal, but the corneal hysteresis is also less as compared to a normal person. But the NTG corneal hysteresis are slightly higher than the POIG eyes. So that means low hysteresis, low compliance, and these eyes are more vulnerable for even get a normal pressure also. Whereas in ocular hypertension study, most of the studies recorded that there is high IOP and high corneal hysteresis. Whereas our study, we found that the corneal hysteresis is almost equal to normal person and normal person with normal IOP. But that means high corneal hysteresis means there is the cornea has a effectively buffer the potential harmful fluctuation. That means the corneal compliance is, ocular compliance is good and there can be tolerate more pressure. That is good for the particular eye actually. So what about the glaucoma progression? All studies, most of the studies agreed that corneal hysteresis was found to be significantly associated with the rate of the visual progression. That means by and large, each 1 millimeter lower of corneal hysteresis is associated with 0.25% per faster rate of visual field index decline. And how it affects the corneal structures, as I already mentioned that high corneal hysteresis means there is more stretchability and more compliance to the posterior segment, posterior part of the eye, especially in the lamina cribrosa and the optic disc area. This suggests that high corneal hysteresis are better able to tolerate the IOP spikes. Conversely, corneal is significantly lower in the primary open angle glaucoma patients. So if you do treatment for glaucoma, what happens is that the corneal reducing the IOP, corneal hysteresis will be increases. That has noted in many studies, but there is controversy also. Sometimes with the high IOP, there is corneal edema also. On decreasing the corneal edema, corneal biomechanics can also changes. So this is a controversy statement. So in day-to-day practice, can we use for risk profiling? Yes. Corneal hysteresis can help for risk profiling together with IOP and CCT. For example, in case of an ocular hypertension, if the corneal hysteresis is low and the pressure is high, and then we have to follow this patient more carefully as compared to a patient with normal corneal hysteresis or high corneal hysteresis with the high IOP. Similarly, in NTG also, there is corneal hysteresis is low with a given normal IOP. That means these patients need more follow-up, more close attention also. That's why I told that the corneal hysteresis is an IOP non-dependent factors for glaucoma. That means in POIG, in untreated POIG with high IOP, corneal hysteresis is low, whereas in untreated NTG with normal IOP, hysteresis is low, and again the other side, untreated ocular hypertension, corneal hysteresis is high. That means corneal hysteresis is not IOP dependent. And if the IOP patient is progressing, even with your best effort, you just can think about the corneal hysteresis. You can reduce your target IOP if the corneal hysteresis is low. And of course, the patient is with low corneal hysteresis for a given IOP need more attention than a patient with corneal normal or high corneal hysteresis. So to summarize, corneal biomechanics are dynamic in nature, is not a static component. The relation between corneal hysteresis and IOP and CCT is not straightforward in glaucoma patients. It can be used as a surrogate marker for measuring the corneal hysteresis of the lamina and optic nerve head, can be used as an IOP independent parameters, and is useful in risk profiling and setting the target IOP in day-to-day practice, especially if the patient is progressing even in your best effort after controlling the IOP with medication or surgery. Thank you, sir.
Thank you, Dr. Faisal, for a wonderful talk on corneal hysteresis. We'll have a bit of discussion only after the session is over. So I'll just say the next presenter is going to be Dr. Prasanna, because Dr. Vanitha has opted out in the last minute because he has to go for some important function. So Prasanna will talk to us on the trabecular mix. Over to you, Prasanna. Thanks for accepting in the last minute. Thank
you, sir. Thank you for the opportunity, sir. Trabecular mix. And grateful to my mentor. I would not be here if not for him. Thank you, sir. And these are the 6 MIGS I'm going to talk, which are currently available in India. And my journey started in 2019 in a wet lab, where you can see these are my own pictures of me holding a stent. And this is a journey that I'm still learning as I'm going through my career. And few of the points that I'm talking is already published, and I'm just going to cover through the same. And the lenses that I am showing in this video are TVG, Glaucos iPrism S6, and the Catena, no financial disclosures. So to start MIGS, it's always, the road is the direct gonioscopy, where the microscope is tilted 30 to 40 degrees towards the surgeon. And I recommend a marking in the microscope so that you are not assistant dependent here. And once the microscope is tilted to you, the eyepiece stooping can just be lifted up. As you can see here, it's a very simple procedure. I've used a lot of videos in this talk. And this is the marking that I use to help me navigate, and I'm not assistant dependent. And then the patient's head is tilted another 35-40 degrees away to break the total internal reflection. And the head is above the heart to prevent blood reflex from the Schlemm's canal. And this is the lens that I use, predominantly the Thornton style stabilization ring, where you can see a thorn-like projection which gives me good hold or good docking despite the block that I use, subtenons or whatever that you are comfortable with. And once the docking is the most important step that you start with, and I also sometimes recommend this kind of movement that you do on either side, and you can see the block is actually here. And then this lens really helps you to navigate a much wider plane. And for a phacoemulsification surgeon, or to convert into the road, is actually start with the Sinski and see how consistent you are to able to touch the trabecular meshwork to see your cognitive 3-dimensional orientation. And once that maneuver is mastered, you are just entering the mixed world. So the microscopes today are very compatible. One important point is there will be an obtuse angle when you operate compared to a phaco where you will have an acute angle. So that is one point that you will notice with the mix. And in this surgery, if you see, the left hand seems to be non-operating, but actually the left hand is what I call the operating hand. The right hand seems to be the operating one, but it is the left hand stability that really decides how you actually do your procedure. And another video of mine here where I wanted to show the full illumination, because when you go under high magnification, the loss of light will be there, so keep it as close to high illumination as possible. And this is another published technique of mine called the overlocking movement. In the early days when I published this, you need to access superior, inferior nasal areas very easily, because the incision should be in such a plane that you will be able to move on either sides just like the overlocking movement. So these are some of the roads ahead, and this is an animation grid of the foot pedal, and it's an unedited video. So once I put the left hand gonio, I'm using my foot pedal to zoom in, zoom out, and I'm now again zooming out so that I identify the main incision. and then I take the instrument in. I'm just going back a bit, it was a bit rushed. So you can see I'm now zooming in, and now I'm fine focusing to get the trabecular meshwork. Now I'm zooming out because I want to identify the main incision, take the instrument, and then do the mix procedure. So this is the most important crux of MIGS, is the left hand or the non-dominant leg, which we need to orient ourselves so that we will be able to get a successful mix procedure. And this is again an unedited video of mine, which is 2 minutes. So once you master it, a few blood from the Schlemm's canal is a good reflex, and it comes like a C-shaped sign, unlike phaco, where you just need to be that extra patient so that the blood gets cleared. Challenges which in your road ahead would be is reflection from scratch, as in this video. I'm just going back a bit. You can see a bad lens which has a lot of scratches will prevent you from seeing the surgical field very well. Excessive pressure on the cornea can actually disrupt your surgical anatomy. All these are my own surgical videos. And collapse of the Schlemm's canal, if you give more axial pressure in your left hand, you can see the Schlemm's canal actually collapsing here. And of course, managing blood inside the anterior chamber is very important. In iStent Inject W, it's very easy to manage because the bleeding will be very minimal. And this is one such Inject W cases of mine, where you can see once the stent is placed, there will be a small amount of bleed, suggesting you are in the right plane. But the challenge is for advanced mixed surgeries like suture gap, when you put the nick with an MVR blade and you try to pass the suture into the trabecular meshwork, that is where the challenge comes, my dear friends, where at every juncture when you pass the suture, the bleed will sometimes, cause hindrance to the surgical plane. The more the bleed, more the blind the procedure will get. So you need to be more careful, use copious viscoelastics. Hyperviscous Helon GB Pro is something I use, and you can see it goes 360 degree and it comes the other side, called the suture GAT, gonioscopy assisted transluminal trabeculotomy. So these are some important steps and tricks for the road ahead. And blood also plays another challenge, especially in this scenario. I just wanted the outside and the inside. I am thinking under eye magnification, the blood is actually inside the AC, but the blood is actually between the cornea and the lens, and I'm again doing the same mistake. So now I'm identifying the mistake, and I'm understood that the blood is between the lens and the cornea, and I'm asking the sister to put saline on the lens. And blood is not your friend in MAGS, so be it inside or outside. So now I've cleared the blood outside, and now when you do the gonio, you will get a clear view of the angle. You can see now the angles are clear. So this is a road, and these are some of the mixed procedures. Bent ab interno needle goniectomy, where we use a 26 gauge needle to do the mixed procedures. I do an inside out technique, be it bang or be it KDB. So these are some modifications in KDB which I've started last 1.5 years or so. You can see that even select angle closure cases, where you can see the iris is slightly at the level of pigmented trabecular meshwork. If you are in the right plane and you open it up, it falls back. And you can also combine it with techniques like goniosynovial lysis as well. Identifying the anatomy and being in the right plane matters. Another modification is if there are frills of tissue that is remaining, you can always use an ILM peeling forceps to just, take it out like a Rexis kind of a technique. And the difference which we are coming out with a paper is KDB, the leaflets are very minimal because you do a complete scoop, whereas in bang you don't do the complete scoop, it's not made for it, and there is a chance that there can be some leaflets that can remain, which can serve as a precursor for peripheral anterior synechiae. And for want of time, I am skipping certain cases here. So this is one important case I wanted to show for the beginners. Things are looking fine, but at this moment, note, my dear friends, at some point there is a small bleed which is not what you expect. So I just stopped here and I'm assessing the area. So this area, there was a slightly posterior extension of the blade, and you can see that you need to know when to stop and what are the indications. So the plane was slightly wrong during one of my earlier stages. If you had continued, you would have ended up with a devastating complication. So as a mixed surgeon, you need to know when to start, when to stop. And there are hemigat, and even suture gat is one surgery that I have started now doing in refractory cases, where this is a post-trabeculectomy surgical case, where you can see a beautiful suture gat that is being done 360 degree, and this is the failed bleb that is seen here. And there are many such collections, but owing to want of time, as well as I'm just trying to summarize my talk, IFEMA can be a common complication which is seen mostly in suture gat, but it is definitely manageable. And most of my work I have published thanks to Shibal ma'am. Some of my extensive work I have published under the guidance of ma'am, and these are some of the series that I have published. iStent Inject, Inject W. I'm not going into the difference of it, but all of my talk you can see I've extensively published it. And this is one such publication, my dear friends. I feel it is the hallmark or going forward, this is going to be revolutionizing MIGS is understanding the angle dynamics post-surgery. There is a clear W sign in KDB, there is a remnant in bang, and there is a suture gate, bird beak configuration in figure D, that is suture gate. So this paves the way, and visualizing post-MIGS, which I published in volume 4, issue 2, I think this paves the way of whole fulcrum of MIGS, where we are able to understand how the angle is actually remodeling itself after MIGS, and Anterion is playing a lot of role in understanding this. So these are some of my data in which I have understood that this is how it works for me. Suture gate and iStent demonstrated the most significant reduction in IOP, with iStent excelling in low complication rate. But however, the number of AGM for the iStent inject patients are quite questionable. So that is why the alternative seems to be KDB. And also the other one road forward could be the combined mix, where, or the compound mix, where you mix a ciliary body procedure with the trabecular meshwork excision procedure. And again, I published that as well. And last but not least, the fond of mix took me into innovations as well, where I made the first MIGS portable simulator in the metaverse, where you can practice not once but multiple times by placing the stent inside the eye, and you can get your cognitive three-dimensional skills refined, and that is another innovation in the field of MIGS. So MIGS is not alternative to filtration procedure. I wanted to take this point right. It prevents the people from progressing, and mild to moderate cases are the way forward. MIGS can do for glaucoma what anti-VEGF is currently doing for retina, and these are some of my publications which have been cited by stalwarts in the WGC podium, and I'm very grateful to Tanuj Dada sir at this moment for giving me an opportunity in this wonderful AV module, and all my videos are actually now published in the module as well. Thank you, Satyan sir, once again for the opportunity. If I'm able to do it, I feel all the neophytes can. Thank you.
Thank you, Prasanna, for an excellent presentation and beautiful videos, and of course, the innovative way of, simulation learning and all. Now I'll call upon Dr. Chandrima. She will be talking on morphometric analysis of glaucoma, BMW, MRW complex.
This mic is on, I think. Yeah, both are on now.
Both are working.
Thank you, Dr. Sunita, distinguished chairpersons. At the outset, I'd like to thank GSI and very specially the President, Dr. Satyan, for this opportunity. So I'm going to take you through the metronome in morphometric analysis of glaucoma, BMO, MRW, and posterior pole. So the optic nerve head evaluation is the cornerstone of glaucoma diagnosis. And if you look at that's the picture of a donut. What we're interested in is not the hole at the center, but the chocolate on it. And that's the neuroretinal rim, which we look at in glaucoma. So here you have the actual picture where you see the neuroretinal rim. This is what we are interested in, and not in the hole out there. So morphometric analysis, striking the metronome, refers to the shift from using Brooks membrane opening horizontal rim width, that's to Brooks membrane opening minimum rim width. That's what we're interested in for assessing the optic nerve, with BMO MRW offering potentially enhanced sensitivity and a better structure function relationship. That's from the Spectralis Glaucoma Module Premium Edition, and I have no financial interest in this. So coming to the actual crux of it, the retinal nerve fiber and the astrocytes form the neuroretinal rim, as you know. But what we're interested here is this part of the story. So the RPE is above the Brooks membrane, which is above the choroid, and which is above the sclera. So what's the true margin, the boundary of the optic disc margin? So the boundary clinically, the inner edge of the sclera, we all know, is the Elschnick's ring and is identified as the disc margin, which you see in green out here. But this is according to the sclera. But clinically versus the BMO-based disc margin, if you look at that, then the BMO base, the red, is here, whereas the green with the sclera is outside. So there's a distinct difference between the two, as you see out here. So that actually raises a controversy as to which one is the actual. But putting all controversy to rest, we have Chauhan et al. Who came out with this, that since the blood vessels and the axons pass through the Brooks membrane, cannot pass through the Brooks membrane, it is the true structural boundary of the, what we're looking at, of the disc. So how to find the Brooks membrane opening in OCT? So here, if you have a look at it, detect the green part the wedge, and this is actually the Brooks membrane opening. So how to find it? The choriocapillaries cannot exist without the Brooks membrane, and so the Brooks membrane opening never ends before the choriocapillaries end, as you see out here, the internally oblique and the externally oblique ones. So in real-time scenario, if you look at it, the ending of the choroid, that is the green part of it as we saw in the previous slide also, and this is the Brooks membrane opening. So the minimum distance between the two is this in blue, and that's what is the minimum width. So the Brooks membrane opening, if you look at it in an animated picture, this actually looks better, is that if you have the Brooks membrane opening out here, the blue line is the minimum distance, and this is the horizontal distance. So the minimum distance is actually more apt, and I'll tell you in a moment's time why it is so. So the Brooks membrane opening actually correlates with the isn't rule that we have when we follow all nomograms in the OCT. But when you're doing it, the Brooks membrane boundary, you need to be careful because it has to be regular like this, because if it has irregularity like this, then you need to check for maybe there could be a blood vessel behind which is actually causing this. So the minimum width versus the horizontal rim width, if you look at it, so here you have the BMO, and this is the minimum width that you have, and this is the horizontal width that you have. So undoubtedly, the minimum width is the more sensitive and the more correct one to use. If you look at these studies, the BMO MRW yielded higher diagnostic performance than the BMO HRW. The sensitivity of the BMO MRW was consistently higher than the RNFL and the BMO HRW. Mean deviation of the visual fields correlated better with BMO MRW. And last but not the least, the RNFL correlated better with the BMO MRW. So the Brooks membrane opening in the Spectralis, if you look at it, the glaucoma module premium edition software has 24 scan lines which detects 48 BMO positions along the ONH to determine the BMO-based disc margin. So this parameter considers the orientation of the neuroretinal rim tissue relative to the point of measurement, and also takes into consideration the highly variable anatomy of the ONH between individuals and quantifies the rim width perpendicular to the trajectory actions. So here we have another interesting thing, that is additionally this software provides an anatomical positioning system where the acquisition data is based on fovea to BMO central axis, reducing the inter-individual variability as the same piece of tissue is examined every time during follow-up. So if you have a look at this, when we do not use the Spectralis APS, so this is what happens. The fovea and the BMO you're seeing on the same line, but that's actually not true. When you use the app, it actually measures, and there you can see it's almost about -4 below the fovea. This also, as you see. So the FBO, the central axis is very important. So the advantage of this is that even in head tilt, or if there is a cyclotorsion, you'd get, despite all that, you'd get an anatomical position, and every time you come for examination, the same part of the segment will be examined. So if you look at the software in normal, so these are the RNFL mapping, and as you see out there, this is what the infrared image is, and there is a distance of, it's not fully aligned, it's about 1.5 degrees below. So if you look at that in 360 degrees, here we have some of the positions where you can see the difference between the BMO MRW and the BMO HRW in the entire thing. So moving to the next, in glaucoma, let us see, that was in normal. In glaucoma, the same thing follows as well. So when you actually measure the fovea and then you see the BMO, you actually get a difference of minus or plus. It's not on the same line. So this is actually much more sensitive than the previous one. So here, this was of a disc which had a thinning, and it had a temporal notch, and this is where the BMO MRW actually maps the temporal notch, and you can actually see it there. So by automatically aligning relative to the individual's the central axis at the follow-up, accuracy is achieved to detect changes as small as 1 micron in the BMO MRW. And this we've already spoken about just now. So So let's have a look at what happens when it's large disk and small disk. So if you have a look at that in a large disk, if you see this, the BMO MRW, and if you see it in a small disk, is that. So this will have a large BMO MRW, whereas a large disk will have a small BMO MRW. So this actually here, the RNFL is more sensitive than the BMO MRW. So let's come to categorizing the ONH in ideal situations. So in ideal situations, when the clinical and the anatomical actually superimpose, then we really have no problem. But let us look at situations like peripapillary atrophy or like cornea temporalis, then what happens? So if you look at this, in peripapillary atrophy, you have the BMO here. In cornus temporalis, because of the reflectivity, you could actually go wrong if you're doing a clinical size of the disc, but in the BMO MRW, there's no chance in doing that. So let us have a look at the different zones. That's the alpha zone that you see, BM and the irregular RPE present. This is the beta zone that you see, where there's the Brooks membrane present and no RPE, and this is the gamma zone that you see. So we are interested in the beta zone. So categorizing the ONH in peripapillary atrophy. So this is where the sclera ends, as you see out there, and that's where the retinal pigment epithelium ends. And this is the hyperreflectivity that is there, which could actually misdiagnose a clinically assessment of the disc margin. So categorizing the ONH in conus temporalis and PPA, that's where the RPE ends, as you see out there, and that's where the sclera ends. So this is where the BMO MRW actually measures up. This is where it is. This is the Brooks membrane opening, and that's the BMO MRW. So this is again just correlating it with what we just saw. So summary of the BMO MRW characteristics. Area influences the diagnostic precision of the BMO MRW, but not the RNFL, mind you. If BMO area increases, diagnostic precision of BMO MRW decreases. So this is the progression analysis. All parameters take into account this axis which we have just spoken about. And so every time your patient comes on follow-up, the same segment will be examined. So there you are gaining over the clinically assessed disc. So improving accuracy in quantitative and qualitative evaluation of the ONH, and thus creating a new world in glaucoma diagnosis. And I gratefully acknowledge Dr. Prasanna V. Ramesh, your contribution with slides and data for this presentation. Thank you very much.
Thank you, Dr. Chandrima, for taking up such a complicated topic and making it simple. Now we will have Dr. Shefali. She will be talking on functional progression analysis.
To thank AIOS and GSI for giving me this opportunity, I am going to talk on functional progression. It's not moving.
Slides.
Slides are not moving.
Yeah. Okay, Shefali now? Shefali,
Is it with this?
Just check now.
Yeah. So at this point of time, we have the strategies for glaucoma progression are functional progression. Visual field is the current gold standard, not only for diagnosis, but also to detect the progression. And other is structural progression. So these are the different strategies for functional progression: clinical judgment, defect classification, event analysis, and trend analysis, which I will discuss a little bit, and more about the literature available. Coming to the clinical judgment, this is how the overview printout looks. That by simple glancing it, you come to know how your patient is, whether the patient is progressing or stable. However, it has its own sets of limitation because this approach is subjective with high inter-observer variability, and the reported level of agreement among experts also varies. Now, Vishwanathan et al., he studied the inter-observer agreement among the general ophthalmologists, where he asked them to grade the visual fields, and he found the kappa statistics only fair inter-observer agreement, and the K value was, that is kappa statistics was 0.32. Tanna et al., he studied the inter-observer agreement and the intra-observer agreement among the glaucoma specialists, who were asked again to categorize the visual fields which were available to them. And he found moderate inter-observer agreement. The kappa was 0.45. However, the inter-observer agreement. That means only when single glaucoma specialist was studying the fields, the kappa agreement was 0.62 to 0.78. This suggests that if the same glaucoma expert is following up the patient single-handedly, clinical judgment may be acceptable. Now coming to the defect classification, mainly what we are what available is AG score and CGIT score. AGs is based on the total deviation and CGIT is based on the pattern deviation. And Professor Hayal et al., they compared the EMGT scoring system with both these scoring system, that is CGITs and AGs, and reported that both the scoring system has good specificity compared to EMGT, but EMGT identified progression earlier and in more number of patients. Coming to the event analysis, we have GCP and GPA, the guided progression analysis we are using more, so I'm going to discuss on that. So let's know what is event-based analysis. Is basically we should have two good baseline fields and subsequent fields are compared to this baseline fields. The advantage of this event analysis is that it can pick up the change as early as from the third field, and another thing is that it compares your patient's data to the stable glaucoma patients database, which is already available in the software. So let's see how any point is seen, or machine takes that any point is progressing or not progressing. So Bull, Bengtson, and Professor Hayal, they tested at each and every location the test and retest variability. And so if this is the one second, any point, this is the pointer. So if your patient's, the threshold, if it falls within this, if it is falling within this range of test-retest variability, it is taken as not progressing. If it is falling outside, it is taken as progressing. So if 3 or more points deteriorate in at least 2 consecutive tests, it is taken as a possible progression, and they are highlighted as a half triangle. And if same points are deteriorate in at least 3 consecutive tests, it is taken as a likely progression, and they are marked as this full triangles, dark triangles. This is very light. So if you see the sensitivity and specificity, Arnalik, Montiel et al., they look for the sensitivity and specificity if you take possible progression as the endpoint, and he found it to be 93% and 95%. However, Artis and Wu et al., both of them, they found that if you take the possible progression as your endpoint, then the chances of false progression are very high. But if you take the likely progression as your endpoint, that it increases your specificity drastically. This guided progression analysis, it has its advantages, like it looks for the statistical change from the baseline test, and whether if this change is persistent. It also takes into account the test-retest variability. It has limitations, like interim test results are not taken into account, and it's dependent upon quality of 2 baseline tests, and it may not identify progression in glaucoma patients with diffuse loss or very advanced loss. Coming to the trend analysis, which is based on the regression analysis, and it needs at least 6 to 7 fields, and one of the important aspects of this is that it gives rate of change over time. So let's see how this VFI summary. Now if you see, once you have 5 or more fields, then you get this VFI slope, and which is plotted against the age, and it also gives you the rate of progression. You can see here there is a rate of, it gives you rate of progression. Another important aspect is that once you come to know that how your patient is progressing. Suppose if no intervention is done at this stage, then how your patient is going to progress over a period of next 5 years. Now the central points are weighted more heavily than those on the periphery in VFI, so that it gives more effective measure of the visual function. See, if this photograph B, you see the number of defects in both are same, but the VFI is 81%, far less compared to the A, because the defects are more centrally located. Now in advanced glaucoma, to detect progression is totally different ball game. You have to rely more on your clinical expertise. You can use 10-2, and if you have glaucoma workstation forum, then you can also get this MD graph slope on, that is, which otherwise you don't get on visual field, other normal Humphrey printouts. Now if you compare the progression on different parameters, which Gardiner et al., he compared the trend analysis of the global indices, and he reported, or he concluded, that the mean deviation detected a larger proportion of patients with progression compared to those the PSD or the VFI. However, he also concluded that no single index, however, was the first to detect every case of progression. Now, Carlos et al., he found a good spatial agreement between the point-wise event-based GPMGT criteria and the trend-based progressor. But what he found was that the degree of agreement between this analysis is dependent on the various factors. Now, if you compare between the event versus trend, then the GPA2, that is the event analysis, detected progression in nearly 16.7% of the eyes more and nearly 6.8 months earlier than the visual field index. That means event is able to diagnose progression much earlier and in more number of patients compared to the trend analysis. Wu and colleagues also found the similar sensitivity. So Medeiros et al., what he did was he integrated both event and the trend analysis, and what he found that since each method provides unique but complementary information using global trend analysis and point-wise event analysis may improve the detection of glaucoma progression. And if you use the Bayesian method, that is the method of pre-test probability, if you combine along with this, you can increase the performance. So to summarize, white-on-white perimetry is gold standard for diagnosis. Clinical judgment has good accuracy only, but only in the expert's hands. So in general ophthalmologists, it should be avoided. Event-based analysis can pick up progression as early as in third field, but you must have good, reliable baseline fields and always change the baseline after significant intervention. Trend-based analysis detect rate of progression of change over time, and if you use the VFI judiciously, then it gives us the idea about the future progression as well. Thank you.
Thanks, Shefali. The next speaker is Dr. Shibbal, and she'll be talking about the laser remodeling for as a first-line management for POAG.
Thank you so much for having me here. Thank you, GSI. Thank you, AIOS. It's a privilege to be amongst friends. After Prasanna's rather dynamic use of the trabecular meshwork and destroying it right, left, and center. Yes. All right? Okay. I'm going to talk of how we preserve the trabecular meshwork. Remember, the TM is an alive structure. It's a dynamic aqueous pump which shunts the aqueous through. And the trabecular meshwork, therefore, is something to be preserved as often as we can. Are we throwing out the baby with the bath water every time we are stripping the trabecular meshwork 360 degrees? Is a question we need to ask ourselves every time we call MIGS minimally invasive, because when you're stripping the entire trabecular meshwork, it is conjunctival sparing, it is not minimally invasive. I'm going to talk of the trabecular meshwork today and how it can be remodeled. Those of us who have enough gray in our hair have been extremely skeptical about remodeling of the trabecular meshwork because we were exposed to ALT in our initial years of practice. But selective laser trabeculoplasty is entirely different from ALT. So I would like you to look at the image on the left. That's a trabecular meshwork that has been lasered by SLT. And on the right are the craters of argon laser trabeculoplasty. The spot sizes are significantly larger, the pulse duration is significantly less, and the damage that you see to the trabecular meshwork is also significantly less, and which is why SLT can be repeated safely and often enough, which is also why SLT is relatively safer. The results, the 6-year results of the LIGHT trial are with us, and it is absolutely non-controversial on this one that this is very, very different from ALT, and hence at 3 years, almost 75% of patients, and at 6 years, as many as 70% of patients post-SLT were both medication and surgery-free while maintaining their target IOP. But what is dramatic is the relative risk of everything between SLT and medication. I'm going to walk you through this slide. There was significantly less disease progression in the SLT group. While medication patients were at 27%, SLT was at 19.5%. There was faster visual field progression. The number of eyes that needed trabeculectomy were more in the SLT group, but significantly less in the medication group. Cataract surgery eyes were similar. The adverse events overall were similar, and ocular adverse events, none of them severe, were also comparative between the two groups. So what we know for now is that SLT provides a stable, drop-free IOP control to almost 70% of POAG patients for up to 6 years. There is a reduced need for surgery. It's a lower cost procedure. There's a lower rate of progression and comparable health-related quality of life results as medication. An IOP drop of 5 millimeters from pre-treatment IOP increase of 5 millimeters, an IOP spike was noted in 1% of patients with SLT, and only one eye of those required treatment. And it has also proven itself to be a reasonable alternative in angle closure with appropriate case selection. Also, the initial cost of SLT, of course, is formidable for most of us who are not in group practices, but the long-term cost effectiveness in terms of health economics of glaucoma is also proven to be inequitable. So then what it is exactly that we have to look for in the future? Direct SLT and the results of the GLORIOUS trials are awaited, but the preliminary data is very promising. Here, the SLT is delivered directly to the trabecular meshwork through perilimbal area. 120 shots, 3 nanoseconds, 400 micron spot size delivered at the limbus over 2 seconds, obviates the need for locating the trabecular meshwork, and there is no contact lens required, so making it much more acceptable to the patient as well. Micropulse laser trabeculoplasty, of course, uses short, low-energy pulses of laser light, preserving tissue and minimizing the risk of scarring while still improving the aqueous outflow. There is no significant difference in IOP reduction, failure, or number of drops between SLT and MLT at 1 year in controlled studies, and there is a significantly lower rate of IOP spikes with MLT as well. This is the newest kid on the block, and while it hasn't reached any of us, it is now documented as evidence. Femtosecond laser image-guided high-precision trabeculotomy flight is perhaps the true MIGS that we will all be looking forward to. At 24 months, there was a mean reduction of IOP by 35%. In almost 82% patients, they reported a 20% reduction in IOP. It was a small group, 18 eyes of 12 patients, and both Vialase laser and the AIOS system have both proven to be effective. If you would look at the small blue box, that's the laser treatment area that's centered over the trabecular meshwork. Those of us who know how to do LASIK will find it easier than anything else. You just make sure that the aligned red dots are overlapping, and that's when you aim the laser and shoot. It is known to be effective over 24 months. On gonioscopy, you can still see the opening that has been made, as the well-defined channels are also clearly visible on ASOCT for after 2 years with no evidence of closure. So what do we know about POAG TMs? SLT can be the first line in treatment-naive eyes and as an adjunct. Emerging protocols using lower energy settings show comparable efficacy with fewer side effects. Of course, the caveat is that we need to continually monitor the glaucoma status with periodic follow-ups, and the COAST trial results are awaited, so we know more about retreatment. The barriers to adoption remain the initial setup costs. This is more true for individual practitioners versus group practice, and health economics of glaucoma versus clinician investment. SLT will pay for itself in the long run if you have a huge patient base, and when you look at something which is minimally invasive and more acceptable to the patient, then this is again something that you are going to have to discuss with your patient, because the acceptability of lasers, thanks to LASIK, is very, very high. But the other part of this is that you have to remember that there is an initial resistance in patients when they look at getting a procedure done on the eye. Apart from this, there is also the impression that a laser is a one-time shop, and then once you've had your laser, you're fine, and that's something that you need to discuss with your patient, that an SLT is not the end-all of glaucoma management. You will need to remain in very, very close follow-up following your SLT as well. What then constitutes a low-resource setting? And again, I'm going to refer to Prasanna's presentation when he spoke of low-resource MIGS. What constitutes low-resource settings? Is it drugs and follow-up that is the low resource you're talking of? Or is it the establishment cost that is the low-resource setting for you? And that is where you need to make your decisions when you're looking at glaucoma practice. Barriers to adoption. The biggest one, the selling point for SLT is that eye drops aren't winning any popularity contests either, and is true for anything in glaucoma. You need to customize to what your patients want, what you think is the best for the patient, and what you think you can do best for your patient. As far as the future is concerned, custom laser parameters, AI algorithms that use imaging data to optimize laser energy and spot placement, improving IOP reduction, predictive modeling. You could look at patients who are responding to Ripasudil. AI can predict which patients will respond best to laser therapy based on angle anatomy and IOP history. Advantages, of course, are precision, consistency, and better outcomes. As is true for laser iridotomies, now we don't think of an Nd:YAG laser for iridotomy as a big investment. Perhaps SLT is to go that way at some point in time. Lasers reduce long-term costs by 30% compared to drops. Better patient outcomes, better acceptance, adherence, fewer side effects, and improved quality of life. Lasers are, of course, paving the way for personalized precision medicine in glaucoma. The setup cost needs to be lower for increased adoption, and that's the low resource setting conversation that we all need to have. Thank you so much for having me here. As is true for almost everything in glaucoma, it's science and compassion that leads to clinical outcomes, and SLT perhaps is the poster child for that.
Yeah. Thanks, Shibal. So next we have Dr. Shweta. She'll be talking about scanning laser ophthalmoscopic capturing of the fundus architect. Shweta, please.
Yes, sir. My slides are not visible. Yes. A very good morning to all. Thank you, Satyan sir, for giving me an opportunity of having me a part of this discussion. And thank you, AIOS, for having me here. So my topic would be capturing the fundus through scanning laser ophthalmoscopy in a much redefined structural matrix showcasing. So if we talk about this, let's talk about the glaucomatous optic neuropathy first, which basically it's a ganglion cell death induced change in the structural architectural manifested by RNFL, which eventually leads to visual field loss, which is manifested functionally. So the core concept of glaucoma lies basically into correlation in structural and the functional changes if we join all the pieces together. And if we want to embark the constellation of glaucoma diagnostic armamentarium, that's a precise constellation making, we all know that the existing visual field changes, they do occur when there are 30 to 40% of RNFL damage. But what if we can design something which clinches the diagnosis morphologically and morphometrically at an early stage, that is something bridging between the already existing one and which we are looking forward to make a perfect constellation of diagnosis. So having said that, what will be the missing piece in the puzzle? It comes as an early diagnosis. And the minute we talk about early diagnosis, the first thing comes in our mind is an red-free fundus photography. But the only limitation of this being a hypopigmented fundus or a myopic fundus, where the reflectance is not so good because the reflection is high and the contrast is low. Then what next? If we go back and look there, the milestones which were there in the field of early diagnosis of glaucoma before the visual field could manifest anything was GDX or polarimetry technique, scanning laser ophthalmoscopy, in the form of HRT giving these parameters, or utilizing the birefringence property of the RNFL with a polarized beam. But having said that, they all had limitations in the form of they were not being used properly, or the results were not to our perfection when the media opacity was there in the form of diatric means. What does that mean? It means any aberrations, myotic pupils, optic nerve head abnormalities, and previous refractive surgery. Also, to overcome this, many changes in the OCTs were also done, which did have their own limitations, especially when it comes to the direction of the RNFL bundles or the reflectance of the RNFL when it is compared to the other layer of the retina itself. That means what? It means when the OCT has a limited applicability for the inter-individual comparisons. Then now, next what? Everything has a limitation. So next comes that the way to the structural matrix, that is redefining the structural matrix from stars to the eye. And this was the concept which came into the picture when the role of adaptive optics was introduced with the SLO. This technology basically utilizes the extraordinarily detailed images of the retina at a cellular level. And the two main parts of this machine would be wavefront sensor that measures the aberrations in the ocular optics, and second would be the spatial light modulator, which compensates for this aberration picked up by the wavefront sensor. So any SLO which is incorporated having all these two parts is definitely going to have an added advantage of redefining the structural matrix as said. Now the advantage of this being would be that it has got a higher axial and transverse resolution with a better contrast and gives us the changes at a much early stage. Pertaining to glaucoma itself, the advantage of this AOSLO would be, if we try to understand the reflectance, how the reflectance from the cytoskeleton of the ganglion cell is gone to the incident light rays, basically it's all about the reflectivity of the RNFL. And this change in the reflectivity is always followed by the thinning of the RNFL. Mind you, the change in the reflectivity is always followed by the thinning of the RNFL. That means before the thinning, this change can be picked up very well by the AIOSLO, which fills the gap in this imaging technology. So now, having said that, different literature supporting the same thing, and if we talk about the images which we have been talking so far, it says that if we see the upper picture which has got a white box beneath it, if we enlarge that white box, the lower box beneath that shows that these are the hyper-reflective images which we are getting through the AOSLO technique, which are not obtained through the red-free fundus photography or the AOSLO free imaging technologies. So now, again, a study said that they did have an advantage of picking up the changes at an early stage and also in a much shorter time. So now coming to you and presenting to you two cases which are definitely from the literature, of course, that a female was observed from 2013 to 2015, and as we can see from the top picture, these are the expansion of the, I'm not getting the pointer. Doesn't matter. So the topmost picture, if you see that these are the expansion of the RNFL bundle narrowing. So when we started in 2013, the part was 272 millimicron, and it further expanded up to 325. We are talking about the narrowing. And with none of the changes were visible on the color photograph, fundus photograph. Only OCT showed the localized thinned out area. Again, coming to a different individual where we could see the expanded vertically AOSLO images. Again, the thinning area, if you see those, if you see those area, these are the thinning which are increasing. And this is and when you see here in this color fundus photograph, the changes are only visible when it comes to the cupping. And in OCT, there is only localized thinning. So now when you talk about these, we come across a new concept of RNFL bundle narrowing. It's not about defects, it's about narrowing. Because the older model said that there is a defect, but the new AOSLO technique, of course, said that the bundles were narrowed, but of course they were present in the areas which were said to be having defects by the red-free fundus photograph or the red-free SLO imaging technology. So now, having said that, again coming forward with one more study, this is the image of a normal individual. This is the image of an individual with moderate glaucoma, and this is the advanced glaucoma. You see that these are the missing gaps which are being picked up by the AOSLO technique. And this study said that there should be, now this picking up of thinning or narrowing is always a subjective matter. So to gain it to an objective way, the study done by Chaudhary et al. Said that there should be a system gain which works as a novel indicator for the glaucomatous optic neuropathy. And at the cellular level, it does manifest and shows that there are alterations in the cytoskeleton. So this objective indicator is going to be more sensitive for the early stages of glaucoma, in contrast to the current gold standard of differential light sensitivity measured on a logarithmic scale. So we can say that these microstructural changes were definitely going to change the glaucoma diagnostic scenario. making it much more possible for us to keep an equilibrium between over-treatment or a underdiagnosis. Having said that, to uncover the tip of the iceberg, utilizing the AOSLO in developing algorithm for early diagnosis, the question still persists there. Can we uncover the iceberg beyond the tip? Thank you very much.
Thank you so much, Shweta. This is really something to look forward to. And to complete this outstanding program that Dr. Satyan has made for us, we have the last speaker and the best, probably, Dr. Mani Bhaskaran, who's going to be talking on electrophysiology.
No pressure, Dr. Deven. Thank you, GSI and the organizers for allowing me to talk here. So you see, there are, when you have something popular, no, you call it as a wave. But one unpopular wave during our PG and fellowship is ERG wave. I hope many of you agree. So whenever the electrode is brought into the patient, no, it looks like a torture device. How many of you have done it yourself? I have done it myself. I did every glaucoma test in the armamentarium to experience it myself. I would recommend it to all the fellows in PG so that when you are prescribing it to a patient, no, you will be cautious about it. I was cursing Satyan for giving me this topic, but I will thank him also now because I learned something. So I'm going to talk about the PHNR, that is photopic negative response, and pattern electroretinogram, a novel electrophysiologist toolkit. I wouldn't really call it as a new one because way back in 2016 we did some study and we are going to kind of share that. But I think some of the new programs with these photopic negative response have come in vogue. So just to go through some basics, and then I will, couple of studies I will elude. I won't go into the complex studies because it's a complex topic. So the pattern electroretinogram, electroretinogram itself is obviously giving the electrical activity of the retinal function to a stimulus of a particular intensity, particular timing, and in a particular background. So it is very lab sensitive. That is something which you should know, and protocol sensitive. So that is one of the reasons why it is probably not universally used and not very popular for practical usage. But this pattern electroretinogram gives you the central retinal function, that is the macular photoreceptors, where the stimulus hits the eye first after reflecting from the RPE, and the retinal ganglion cell layer function. Let us go through that basics to see how this gives you that. So basically it is an alternating contrast reversal, black and white checkerboard, like how my shirt is. See, Dr. Satyan, I am walking the talk. I know. Using gratings, constant mean luminance is there, and signal strength of 2 to 8 microvolts is given as the stimulus, and the electrodes collect the electrical activity and gives us in a waveform. So basically this differentiates optic nerve and macular dysfunction. So this is how the checkerboard pattern is, and there are two different PERGs. One is the transient PERG done in an undilated pupil, and with or without refractive correction also you can do this, and it takes 2 minutes and 10 seconds minimum. The total test takes around 10 minutes. And there is something called steady state PERG, which is a little elaborate one, takes more time, but it requires a Fourier analysis also. But most of the PERG used in glaucoma are the transient PERG with using this reversing checkerboard pattern here, and you get this kind of wave. Of course, the steady state PERG with the new programs are being used, something called S-sensitive, S-cone ERG, which differentiates it from the L-cone so that it separates out the early dysfunction using the retinal ganglion cells. So that is also getting popular recently, but I'm not going to allude into it because it is something which is emerging. It's called the PERG-LA and also PERG-X. So these are some things which are coming up, and so that will not be discussed in this talk. Now this is the waveform that is coming. So the N35 is the first negative response which belongs to the photoreceptors, and the P50 is a positive wave which gives you the oscillatory potentials from the murines, the Muller cells and the bipolar ganglion cells, and the N95 is the negative response which reflects the RGC function. So P50 reflects the macular function, and usually it is 45 to 60 milliseconds, an average of P50. That's why the name P50. And N95 is around 90 to 100 milliseconds from the time of stimulus. So that is this thing. So the amplitude and the implicit time are calculated according to these arrows that are given. So photopic negative response gives you the functional assessment. It was introduced first by Vishwanathan et al. In 91 actually, using red flashes on blue background. So what happens is when you have the blue background, it eliminates the rod response and isolates the cone response only to stimulate it. It was used first in the macaque monkeys, which gave excellent values, but unfortunately when it was reproduced in humans, it was not that popular. But the reduced photopic negative response amplitude compared to normal subjects was useful in isolating the retinal ganglion cell function, which is directly related to glaucoma. Conventional visual field can detect only at 30 to 35% of damage, and even the OCT RNFL thinning starts when there is an 18% to 30% of functional loss of retinal ganglion cells. That is some of the estimates that we have, and that is where the PHNR or the ERG comes in, because it picks up at that early stage when the function is lost. So first the ERG, then comes the OCT, then comes the visual field damage. That is for for us to remember. So the stimulus patterns are like this in PHNR. So white on white broadband, basically it is a overall stimulus. That is what is usually used, and portable ERGs also it is being used. Unfortunately, portable ERGs are not very popular because the protocols cannot be kept constant. Red on blue is the most popular which gives you the best response for glaucoma, and blue on yellow is another monochromatic stimulus. We will be talking about a study which we did looking at all these three. So basically the red on blue was better to detect glaucoma. Also blue on yellow showed good results in many of these studies. So this is the one study which I'm going to talk about on PERG in glaucoma. I hope some of this is visible. So basically there are three groups: 50 normals, 50 patients with pre-perimetric glaucoma, and 50 patients with established glaucomas. And you can see this P50 latency and the N95 latency is recorded here for each of these groups. But you can see the amplitude in PERG. Remember, the amplitude difference is what is taken. So actually the topic should be like PERG amplitude. So that's what differentiates the glaucoma patients. And you can see that the pre-perimetric glaucomas as well as the glaucomas were showing similar reduction. So that is what you have to take home message here, because these pre-perimetric glaucomas are supposed to have some functional loss, and that is reflected here. To some extent, that is why these PERG are useful in early diagnosis and progression, but it is not useful beyond a certain stage, because this lowering of the thing doesn't progress beyond that. So that is something which you have to think about in terms of progression part of it, even though new protocols like what I said are useful. Now this is the AUC for RNFL, which is equivalent to the N95 amplitude in this case. Of course, it is just the macular function, and we cannot detect anything in the periphery except of course in MFERG, which is a different subject altogether. Now this is the study which we have done. I hope they have time to allude to this quickly. So 50 controls and 25 glaucomas we had, mostly moderate and severe, but few mild cases were also there. This is a busy slide, but you can see that the three different stimuli, the broadband, red on blue and the blue on yellow, showed different significance between in the PHNR. There is a photopic negative response here. All are significantly reduced amplitude. And this is a case example of a 45-year-old who went through all these three, and you can see that the reduced PHNR is seen in all of them compared to the age-matched control. So of course, by looking at it, we will not be able to tell which is the better one. So looking at this correlation here between PHNR amplitude and mean deviation, you can see that the red on blue stimulus has the best correlation. Similar to that is the pattern standard deviation. Again, red on blue scores better. And you can, second one is the red on blue, okay, so for your convenience to see. And the RNFL thickness, again, if you are looking at it, that is again the PHNR amplitude was across the board correlating all the stimulus. That is something which you have to think, because it is much more closer to the functional thing as well. Now this is between the MD and the RNFL thickness to show that that correlation is slightly less, as we can understand. This is when we looked at the mild, moderate and severe glaucomas, and we can see again the red on blue is scoring better in all these the PHNR amplitudes. This is a post-hoc table comparing the normals versus the various groups, and again red on blue was much better for the photopic negative response. As you can see here, there is distinct difference in the box plots as well. ROC again, red on blue, was better, and it was even comparable to the RNFL thinning itself. So there are limitations as we know about this thing. So to conclude the key points, the pattern ERG and photopic negative response are objective measures of retinal ganglion cell function. Visual field conversion and an increased rate of progressive retinal nerve fiber layer thinning were shown, and converging evidence shows that there is a reversible aspect of dysfunction in glaucoma. When they did the trabeculectomy, it reversed the ERG pattern, and that shows that we can actually have some reversal of function. Advancements in OCT actually limited the role. So in pre-perimetric glaucomas and glaucoma suspects, sometimes we do this PHNR to see if we can start the patient on treatment. That is the only application that I can think of as of now because of the practical difficulties. Thank you very much.
Thank you so much, Bhaskar. Thank you all, the presenters, for your wonderful talks. And if you have really noticed the topics, what is that we have given is all very different, though it is all we are all practicing. But if you go to the specifics, are we really doing the CCT, and are we really able to understand the corneal hysteresis? Are we really doing the SLT? How much we really look into the progression by looking at the visual fields? So every topic has its own plus in that. So the idea is how much that we really practice in our day-to-day, like what Bhaskar was mentioning about the PHNR or the pattern ERG. So before we go for a full discussion, we'll have some questions before that. And Faisal, you have to go to your other hall. Somebody has any questions for Faisal on CCT, more of a corneal hysteresis? We'll be more than happy to have some questions, so we can release Faisal to go. Yeah, please, anybody can have.
So, yeah,
Faisal,
I think generally in clinical practice.
Just take one mic if you can, or you can just go there and then.
So in the clinical practice, we are generally using CCT, and we do not have ocular response analyzer. So in our setup, and it is not available with everyone. Yeah. It is not a very common thing to have. So for people like who do not have ocular response analyzer, how do you measure, and what are the clinical implications if you do not measure hysteresis and just the thickness?
Yeah.
Can you just little refine that?
Yeah, so
is that you feel without an ORA, do you feel that we are missing out something?
Yes.
Sir, maybe in very selective few cases only, because initially the ORA was very much, lot of people are using. Now most of us are, even we are not using regularly. We are sending some patient to the refractive side as like, especially those who had previous history of, refractive surgeries, maybe past history of LASIK or something. In that scenario, sometimes we can do a corneal hysteresis and further documentation whether hysteresis has any changes pre and post refractive surgery. And sometimes in normal tension glaucoma, if everything is done, patient is progressing, just see look for corneal hysteresis things.
So there are certain situations where you assume that these conditions will have low corneal hysteresis, and your decisions, clinical and surgical, will be based on that.
Most of the cases, we are not deciding just only about this corneal hysteresis, but we have to correlate the corneal hysteresis and CCT and the other parameters also. Just a contribution to the other parameters. The myopia it's kind of varying, the value will be varying because the myopia itself will, make the changes in the corneal hysteresis, because the myopic eyes are more, more resilient, more complaint. So the myopic, the corneal hysteresis will be, it's not much good actually. So in our own data, angle closure eyes and the normal, in normal patient, there was no statistically significant difference in the PSCD and that means PSC and PSCG as compared to normal eyes. But some studies shows there are minimal differences. Our own experience, we did in 2012 only we published that data. That data showed there was no significance between normal patient, normal healthy object and the angle closure disease.
Faisal, if you want to give a take-home message for the audience.
In a sense that, see, from a clinical perspective, whether the test is important to integrate in day-to-day practice or not.
It's not much important.
Okay. Is that in some patients you feel it is very important that we need to do a ORA and then look at it?
Maybe that's when if that you achieve the target IOP, but patient is still progressing, you would not get other reason like vascular event is not there. Then you just see what is the corneal hysteresis, and depends on the hysteresis. If the hysteresis is low, then you just reduce the target IOP again a little bit.
Thank you so much, Faisal, for your answers, and we will just release you to go for your next session. Thank you. Rajul, you want to ask something? Yeah, there are, yeah.
Sunita also has some queries.
Yeah, please. Any topic.
If audience, for the males, I think it's a very common.
Yeah, from the audience, if they want to ask any questions to any speaker.
I'm Dr. Sunil Shah from Varanasi. I've been using this DAPSIS pattern ERG machine for last 5 years, and we have got a very encouraging results for pre-perimetric glaucoma. I agree with Dr. Mani that this test should be incorporated in all those patients who have got pre-perimetric glaucoma, especially in myopes or thin corneas, or where there is a family history, but all the tests are normal. So to have a patient who has got a ocular hypertension, or to level if it is going to be a glaucoma later on, I think pattern ERG stands such a place in our practice. So I would like to know from Dr. Mani, are you getting referrals from the doctors regarding the your results? Because this is a very, very important tool, and it has been approved by American Academy of Ophthalmology also.
Yeah, I agree. The only issue is the practical part of it. For pattern ERG, you need to put the electrode on the cornea. So that is one thing. Of course, it is quick and easy to do if you have a technician who is well versed with it. So and then again, the protocol is lab sensitive. So you need to create that particular protocol and make sure that the protocol is stuck to and keep auditing. So those are the issues. But I think in such glaucoma suspects and pre-perimetric glaucomas, it has a place if you have the machine and if you are having.
I just want to. We have this problem of the different types of lab technician handling. We have assigned only one lab technician, and the machine is kept only at one place. And we also calibrate every year. So this is the most important thing, that you have to be careful that all the parameters should be same and the machine should be calibrated every year or whenever you have a suspect.
I'm really happy. Why I gave Bhaskar this particular topic is, it all depends upon each machine. What Bhaskar uses is a different machine, and what you are talking is completely a different machine. What you are talking is a diopsis, is a different sensitivity and specificity, versus the complete technology is different in the, I don't know whether Bhaskar has a diagnosis or Roland's, I don't know which one he has. Both are completely two different systems. One, you have to do the dark adaptation and then do it, and then the sensors are kept on the cornea. In diopsis, it is completely on the outside. If you really see the waves, pattern itself is completely different. One gives the sine wave, other gives something like what Bhaskar was showing, a single wave pattern, that is N95 wave pattern. And also in the pH channel, the sensitivity in diopsis in comparison to the diagnosis or from the Roland ERG is completely different, because these two machines, especially the diagnosis, is being used in the space. Diopsis is being used as a clinical ERG, which is not having that higher sensitivity, which we need to understand. But that is one of the most easiest machines. We do have one. That is the most easiest machine that you can use it. But you cannot really take every wave as abnormal It all depends upon how much you really clean the eyelid or the lower lid, especially mainly, and how it sticks to the eye. There are so much of variabilities which we see. We do that, but it is not a very regular or daily usage tool that you can go and do it. But what Bhaskar was mentioning is because we have to do the dark adaptation, that is completely a different lab settings. So these are two different scenarios, but the ERG in certain cases where you have a confusion, especially in early glaucomas or ocular hypertensives, where you really want to treat or not to treat.
So
may help
Bhaskar,
you out.
can you just comment that when you say pre-perimetric or glaucoma suspect, how will you use in clinical practice?
Say, for example, I don't do that in the first visit itself. I'll be following up, and then the patient gets really pesty, They want to know what is happening, especially when they are so, agitated because there is a family
let's give
history.
hypothetical situation that perimetry is normal.
OCT also is normal.
And you have this PRG abnormal.
Yeah, so if,
So how will
for
you-
example, high-risk ocular hypertensive, more than 25 millimeters of mercury consistently recorded and probably on or not on medications. Or a patient who is a glaucoma suspect whose disc is looking like that, and sometimes a disc hemorrhage is seen, but subsequently no visual field changes are there. You want to establish that, okay, this patient will require medication or not. That is the only scenario I would be using this.
Yeah, that is one thing, Bhaskar. And what is that we have noticed is, say for example, the family history, there is a significant progression happening in the family in spite of the so-called target IOP.
Yes.
The children who come with the suspicious plus or minus, and when you do the ERG, either you do the PHNR or PERG, it really helps in some situations where the family where they have a significant progression. If you can really detect these people much earlier, then the possibility of reducing the risk of developing into the faster progression in these patients are quite useful. That is another scenario which I see is a potential use of both the pattern ERG as well as the PHNR, which is much more sensitive because PHNR is more focused only on the RGCs.
So one quick comment on that is, say if you don't have a PERG, glaucoma works with the risk factors. The number of risk factors or more, I would probably treat these patients rather than waiting. This will give you an objective evidence that there is a functional loss. So that is the
Sibyl,
only
I
advantage.
just want you to be there for a couple of minutes. I know, yeah. Yeah. So thank you. Regarding the ERG, we have some discussion. Anyone has?
She has a query for.
Please, please.
No, I have a question for Shibal only. She has presented
We are not
light
leaving you,
trial,
Shibal.
and light trial has really shown very encouraging results. At the end of 3 years, 70% drop free, and at 6 years, 74 and 70, and in mild, moderate, and even advanced glaucomas, and target pressures could be achieved. So what is your like in India, we had not been doing so much SLT, but now we have machines. And so what is your recommendation for everyone? Like, should it be the first line treatment? In European guidelines, it has been now, considered as the first line treatment for treatment naive patients and all. So just
So the NICE guidelines are very clear that drops as well as SLT are now considered first line. When you look at larger health economics of glaucoma on a national scale or a scale which is more than your individual clinical practice, SLT should become your first line of treatment. But as long as it's an individual practice, finding SLT to be first line of treatment is not going to be simple. But adherence being what it is, if we can get a patient to agree, and even if we offer 2 years, 3 years, 1 year drop free, it makes a significant difference to your not just the ocular surface and the health related quality of life, but also your subsequent filtration surgeries.
Yeah. Definitely, if you can do a proper gonioscopy and then you identify there is definitely an open angle trabecular meshwork is seen, you do a SLT, you will have a result because a lot of, I feel there is no real controversy. We have done about 1,600 patients for our inclusion in the SLT trial from Luminous, and the results were similar, like at least 10 to 15%. It is about 12.6% was the difference between the medication group versus the SLT group, where the progression was more in the medication group. Obviously we know the reasons. Probably the patient may not be using, or the diurnal fluctuations, everything was much higher in the medication group in comparison to the SLT group. It is that mindset we have even now, whether the SLT is useful or not. I feel the SLT definitely has a role to play. It is how you really do the gonioscopy and adapt to this. Anybody in the institutions, all of you have been using Bhaskar, Dr. Chandrima, Shifali?
Yeah, SLT is definitely underutilized. That is only because I think in practice, the machine cost as well as the, initially when the patient comes, whether to tell him or not, because the patient utility, he has a thing, okay, I have to have a laser instead of just putting the drops.
Yeah.
So that mentality is also there. So what I do is I prime the patient first time when I see. I'm a great advocate of SLT, by the way.
Okay.
So when the patient comes, the next time is prepared for that. I say there is an alternative. You want to consider it. Next time we can think about it, and he definitely considers it and goes for it.
Yeah, because the country like ours, where the utilization of the medication is so poor, it is one of the best things that we can definitely offer to all our PYAG patients. Leave out the PACG, obviously it is not going to be useful, but I think PYAG, your first choice, definitely an SLT is a definite choice.
I think only
Thank you, Sibyl. I think I should leave you now. Thank you.
If you do SLT, I think we must counsel patient properly, because they will need proper follow-up, because of what happens once we do some procedure, it becomes mindset, now my glaucoma is gone. So that is, I think, because if patients are not putting the drops, then definitely after some procedure, they may not come out for follow-ups.
Even if you give the medications, they don't come back.
Shibal, other thing, health economics, you said that cost effective SLT would be cost effective, but all is the Western data. So from Indian perspective, we have to analyze considering that we have much cheaper drug also available. I'm not saying SLT is bad. I'm just saying we always got the Western data about the cost effectiveness, but the Western data they have a much expensive medication compared to India. So in India, the cost benefit ratio would be much different than what we see in the literature.
So we're looking at Quali and Dali. This is also the health economics data from when I was a resident, when Australia did a mathematical modeling of it on generics. So we will be cheaper, definitely.
100% cheaper.
Definitely.
100% cheaper. I'll tell you, Rajul.
It would not be 40%.
No, I'll tell you how it works. Say, for example, SLT, at least I do it at 3,500 rupees, or you may be doing it 13,000 rupees. That is different. But the cost of the procedure, the patient will take out within no time. That I can assure you on that part. I'm not promoting the SLT here.
I'm really sorry to interrupt,
yeah.
But when we look at health economics of glaucoma, the more important metrics are not just the cost of medication, but also disability adjusted life years and quality adjusted life years. And in all mathematical models, with the cost of generic medications being what it is, even 17 years ago, and I forget the name of the author, and this was one of the most spectacular mathematical models I've ever looked at, SLT proved to be cost effective with generic medications.
Yeah, see, in health economics, yes, Sibyl, what you said is true. In health economics, we do add, it is not only the IOP drop, we add the cost for the adverse events, patient not coming back for the treatment and progression of the disease, and number of visits the patient comes back for all the other problems. Everything included. SLT definitely, there is absolutely no doubt about that scores over that.
So for me, the biggest problem has been the patients accepting SLT. So it's like laser, they're scared of it. And the second thing is, the first thing they say is, Acha, 6 months let us put drops and then we'll think about laser. So unless we educate, every ophthalmologist is talking SLT, only then it will go deeper. But we have to be first convinced, and I am convinced about the use of SLT as the first
anyway,
line.
we are not here to promote SLT, but we are just
definitely
looking
I have no
at
financial
how the
interest.
SLT can be best utilized.
So I think I'll request Dr. Satyan to give a final comment, because the time is up, and we have a group photograph also for.
Yeah, we'll have our group photograph. I really wish to say thanks to everyone of the speakers, and also thanks so much all the audience. Without you, the session is not going to be complete. Thank you all for being here today, and we'll see you soon in September 12th, 13th, 14th in Bhopal. Thank you.